Assalamu alaikum. Very warm welcome to our public health webinar. I am Mahmoud Shah Hussein, professor at the Institute of Public Health at the College of Medicine and Health Science, United Arab Emirates University. This webinar is a part of the global campaign, This is Public Health. We are also very proud to be affiliated ASFER, Association of School of Public Health in European region. We organize this webinar on the monthly basis with the aim of bringing interesting speakers in order to highlight different important issues of public health. This webinar is accredited by the UAE University for 1 credit hours. So to ask you a question, click the Q&A option in the middle bottom of your screen. You can submit your question during the presentation and we will try to cover all the questions in the end. At the end of this webinar, we will share the link in the chat box for evaluation of the webinar, and you will need to fill this evaluation in order to obtain your certificate. This webinar is recorded. The recording will be posted on YouTube channel. To reach our channel, search on the YouTube Institute of Public Health, IPH. Now, allow me to introduce our colleague, Dr. Aqeel Saleem. He is adjunct professor at the UAE University. Dr. Aqeel, he obtained his residence in the internal medicine from the University of Pittsburgh, Pennsylvania, and his infection disease fellowship from the University of West Virginia, Morgantown. He practiced infection disease in United States for extensive time. Then he moved in UAE as a consultant of infection disease up to date. Dr. Aqeel is a director of infection disease and a chair of antimicrobial and a chair of infection control in Tawam Hospital. He published numerous articles in peer-reviewed journals. So the topic of his presentation, it is all what you need to know about monkeypox. Dr. Aqeel, please, very warm welcome. The floor is yours. Thank you.
Yes, Dr. Aqeel, you can start sharing your screen and unmute your mic. Dr. Aqeel, you're muted at the moment. I think you need to unmute.
Thank you, Professor Mahmoud, for kind introduction. Me and Professor Mahmoud have done several presentations together. Thank you for the organizers, Dr. Azhar, Mr. Ismail, and others to give me a chance to present on monkeypox. You know, I think these days most of us are focusing on COVID, influenza and others, but we tend not to have a discussion on monkeypox, which is also very, very important topic. So objectives for today's talk would to understand the epidemiology of monkeypox, mode of transmission, clinical manifestation of monkeypox, diagnostics, how you can diagnose monkeypox, management of monkeypox, and the most important thing would be how would you do vaccination for the monkeypox. So these are the important things, and also probably people have a lot of questions about management and the other things that we are going to discuss shortly. So as introduction, monkeypox is a zoonotic disease that results in a rash similar of smallpox. So if the people are thinking that it's a variant of a smallpox, it is not, but it's a similar zoonotic disease that occurs in humans and also in animals. However, historically, person-to-person spread outside the household and the mortality from a monkeypox infection are significantly less than smallpox. We remember smallpox it's been eradicated, and we don't have smallpox. We don't see cases of smallpox anymore. The rash of monkeypox can also be similar in appearance and more common infectious rashes. Um, if you see a rash of a monkeypox, I'm going to show you, you will probably think it might be a secondary syphilis, herpes simplex infection, and varicella virus infection. So these are the rashes that probably you will think that these are the ones that would be appearing similar to monkeypox rash. So monkeypox, the pathogen, monkeypox virus is an enveloped double-stranded DNA virus that belongs to orthopox genus of Pox viridae family. It's a double-stranded DNA virus, so it's important to understand. There are two distinct genetic clades of monkeypox viruses, the Central African, which is Congo Basin clade, and the West African clade. The Congo Basin clade has historically caused a more severe disease and was thought to be more transmissible. Now here I want to illustrate a little bit more about this epidemiology. In 2003, the US had also discovered a strain of monkeypox, but then it went into hibernation, and then in 2021 and 2022, we are seeing cases of monkeypox, 2022 mainly. So, Mr. Smile, I'll come to our first question. We'll give you 30 seconds for this question. It is interesting for you. So monkeypox transmission occurs by which of the following: contact with rash, with varicella, contact with respiratory secretions, patient with COVID-19 has high risk, and immunocompromised patients. So just click A, B, C, D, or 1, 2, 3, 4, and then submit your answer. And then we will see how many of you have gotten correct. Okay, we can see the answer now. Okay, so contact with varicella rash, contact with respiratory secretion. I'm going to mention it. The varicella rash contact is different. If you contact with varicella rash, you're going to get varicella. And monkeypox is different virus. So contact with respiratory secretion is the correct answer. So we can close this now. So monkeypox mode of transmission is unprotected contact with respiratory droplets with patient who has monkeypox. Lesion material, that's, I'm going to show you the lesions. You might see it, few lesions here in this cartoon. Body fluids, contaminated material and surfaces. And the virus can enter through respiratory tract, mucous membranes, eyes and mouth, and broken skin, example, animal bites. So these are the mode of transmission of monkeypox. The incubation period is between 5 to 21 days. Infection with monkeypox virus begins with an incubation period which lasts from 7 to 14, but it can range from 5 to 21 days. So there are stages of incubation period and the infection period. First stage is prodromal stage. People with monkeypox will develop an early set of symptoms, which is prodrome. A person may sometimes be contagious during this period. So here we can get second question. The monkeypox symptoms include so here also you have the pool, you have 30 seconds. The symptoms of monkeypox includes following: flu, aches and pains, a rash, or all of the above. Please you can answer it. can do A, B, C, D, or 1, 2, 3, 4, whatever you like, 30 seconds. Flu, aches and pains, rash, or all of the above.
If I just may add, your answers are anonymous, so even if you answer wrong, it's okay. You can just answer.
Yeah, please answer. We'll not tell, it's anonymous. Okay, I think we can show the answer. Okay, very good. So 93% said all of the above. So as we know, we can close it. Uh, that this is a viral disease. Monkeypox is a virus, as we discussed in the previous slide. So it would include all flu, aches and pains, and rash. And so this is answer is all of the above. So symptoms first include fever, malaise, headache, sometimes sore throat, cough, and lymphadenopathy. So lymphadenopathy is the pathognomonic sign of this monkeypox, and lymphadenopathy is distinguishing feature of monkeypox from smallpox. So since smallpox is eradicated, but maybe in some developing countries you can see few cases of smallpox, but in smallpox you would not see lymphadenopathy. Typically, lymphadenopathy occurs with fever onset 1 to 2 days before the rash onset, or rarely with rash onset. So lymphadenopathy is pathognomonic feature of monkeypox. Lymph nodes may swell in the neck, submandibular and cervical region, armpits, axillary or groin, inguinal, and can occur both sides of the body or just one. So lymphadenopathy, fever, malaise, headache, sometimes sore throat. These are the symptoms that you will get. Again, the illness begins with fever, headache, myalgias, body aches, swollen lymph nodes, chills, exhaustion. I'm sure everybody has probably encountered um, quite a few times viral illness. Probably they have encountered fever, headache, body aches. These are non-specific symptoms. So later stage, this is called a rash stage. Following the prodrome, lesions will develop in the mouth, on the body. Lesions progresses through several stages before falling off. So I will show you the stages where the lesions go. A person is contagious from the onset of exanthem through scab lesion. So it goes from vesicle to crusting off of the lesion. The skin eruption usually occurs between 1 to 2 days before and 3 to 4 days after the onset of systemic symptoms, and continues for 2 to 3 weeks, although rashes without systemic illness has been reported. So this rash is quite a specific rash. Let me show you the picture. You can see the rash here, upper part of the body. You can see on the wrist and the upper arm. You can, these are the vesicles you can see. These are the papules, macules, papules in every type. And these, the first picture shows little bit crusting lesion. So the rash associated with monkeypox is often described as painful, but in the healing phase, crusts can become itchy. Remember, the rash needs to be differentiated between the herpes simplex, syphilis, and varicella zoster rash. The number of lesions varies from few to 100. So we have not seen multiple lesions more than 20, 25, or maximum 100. If it's more than 100, then probably it is not a monkeypox. So most commonly, the rash or the lesions are ranging from 1 to 20 on the skin. Cases more than 100 lesions have been extremely rare during 2022 outbreak. So now over here, you can see lesions progressing through the following stages before it's falling off. So here you can see a macule, you can see a papule here, then a vesicle, then a pustule, and a scab. The scab falls off, and after that, the person is not infectious. So macule, papule, vesicle, pustule, and the scab. The scabs falls off and the person is not infectious after that. Laboratory findings, multiple non-specific laboratory findings can be seen in patients with monkeypox. Abnormal aminotransferases, that is LFTs, AST, ALT, alkaline phosphatase, bilirubin. There could be leukocytosis or leukopenia. There could be thrombocytopenia and hypoalbuminemia. There are non-specific laboratory things. What are the specifics? We are going to come on that. If the diagnosis of monkeypox is suspected, providers should send specimen for testing. What are the specimen? It's a PCR for orthopox virus DNA should be performed on lesion samples. Now the lesions I just showed you, you might have to get those lesions. Lesions should be vigorously swabbed to collect skin cells that come off the lesion. So the lesions, if they are not in the phase of scabbing or vesicle, it should be vigorously swabbed, and then you can collect this specimen. Unlike lesions seen in those with herpes simplex, unroofing is not required. So you don't need to unroof, because the skin cells, if you swab them vigorously, you can get the DNA virus. The content of monkeypox lesion is often solid, so that is the reason that you don't need de-roof. So patients with monkeypox typically have detectable levels of anti-orthopodic IgM antibodies during the period of 4 to 56 days after the onset of a disease. Now this is a blood test. IgM, you can see the previous was PCR, which you have done through the swab, and CDC developed an IgM capture and IgG enzyme-linked immunoassay ELISA that demonstrated recent monkeypox virus infection. So we can also send out the IgM and IgG blood immunoglobulin levels to monkeypox to send out labs. Serum IgM and IgG antibodies detected 5 and 8 days after the onset of the rash. So remember, once the rash is there, then you can find IgM and IgG. Next question, Mr. Smile. Monkeypox patients should be isolated until the patient is afebrile, until skin rash scabbed over and fallen off. Patient's PCR is negative once white count is normalized. So I just discussed, I think few minutes ago, what would be the appropriate isolation period for those people. Isolated until the patient is afebrile, until the skin rash scabbed over and fallen off. Next, patient's PCR is negative once white count is normalized. Okay, we can show the answer. Okay, very good. So I think people have probably listening. So until the skin rash scabbed off and fallen off, this is the correct answer. We can hide it now. So differential diagnosis of rash, monkeypox rash is, as we were discussing before, was varicella, herpes simplex, other sexually transmitted infections like Haemophilus ducreyi or molluscum contagiosum. These are the differential diagnosis, and it could be secondary syphilis. It is included in sexually transmitted infections. So case definition of monkeypox according to CDC 2022 Suspected case, the patient has new characteristic rash or meets one of the epidemiological criteria, that is, there is high clinical suspicion of monkeypox consistent with an illness confused with monkeypox, such as secondary syphilis, herpes simplex, or varicella. This is a suspected case. Probable case would be there is no suspicion of other recent orthopox viruses, example vaccinia virus, and this is a vaccine ACAM 2000 vaccination, and there is orthopox virus DNA detected by PCR testing by clinical suspicion, or orthopox virus detected during immunohistochemical or electron microscopy methods, or the patient has detectable levels of IgM and IgG in 4 to 56 days. And confirmed case, the above were suspected and probable cases. The confirmed case, monkeypox virus DNA is detectable by PCR testing or next generation sequencing of a clinical specimen or monkeypox viruses isolated in a culture form. We don't do cultures, we just do PCR, and we have seen quite a few PCRs positive, becoming positive these days. And then we usually transfer them to our one of the hospitals that is for communicable diseases. So the management of the patient with monkeypox usually involves supportive care as well as antiviral therapy for selected patients. I will discuss the antiviral therapy in a little bit. Supportive measures, many patients with monkeypox have mild disease. Most of the patients, I would say, have mild disease and will recover without any medical intervention. So supportive care requiring hospitalization may be warranted for those who are at risk of dehydration, example, nausea, vomiting, dysphagia, severe tonsillitis, or those who require more intensive pain management and those experiencing severe disease or complications. Antiviral therapy, at this time, Tecovirimat is the treatment of choice for the patients following: those who have severe disease, for example, hemorrhagic disease, confluent lesions, encephalitis, which is still rare, or other conditions requiring hospitalization. Or those at risk of severe disease, those would be people younger than 8 years of age, people has history of presence of atopic dermatitis, persons who are pregnant or breastfeeding, people with complications such as secondary bacterial infection, dehydration, pneumonia, or immunocompromised patients. So immunocompromised patient definition over here would be, as per CDC, those who have advanced HIV, AIDS, CD4 count less than 200, leukemia, lymphoma patients, malignancy, solid organ transplantation, they are on therapy, or people who have leukemias, lymphomas requiring radiation, or the people who are taking tumor necrosis factor inhibitors, high dose corticosteroids. The other immunocompromised patients are a recipient of hematopoietic stem cell transplant less than 24 months post-transplant, or more than 24 months, but graft versus host disease or disease relapse, or having an autoimmune disease with immunodeficiency as clinical. Now, if Tecovirimat is not available, which probably in most of the places is not available, we can use cidofovir or brincidivir. Now, cidofovir is available here in UAE, we can use it, but we haven't used it in a lot of people. Now, in Ain region, the monkeypox pathway, so this is important, that how we manage or how we go through the monkeypox pathway in Ain region, in our region. So presenting history, contact with infected animal fluid, bite or scratch, contact with infected person through skin lesion, body fluids, respiratory droplets, or contact with contaminated material. And signs and symptoms would include fever, myalgia, headache, followed by lymphadenopathy. Rash appears within 1 to 3 days, starting in the face and then spreads to the rest of the body. The incubation period, as we discussed earlier, 6 to 13 days, but it can be as early as 5 to 21 days. Now, monkeypox suspected cases, as by our pathway, admit what we should do. Step one, admit to a single patient room with negative isolation. So negative pressure isolation is a must. Or if we don't have a negative pressure isolation room, HEPA filter shall be placed in the unavailability of negative pressure room. Airborne and contact isolation. Uh, Personal protective equipments like gown, gloves, eye protection, and N95 mask. Maintain adherence to hand hygiene. Consult infectious disease, e-notification to Department of Health. Now, how to diagnose? As we said that we are going to collect the PCR, order and collect 2 skin swabs, monkeypox virus PCR, 2 different locations, or blood PCR monkeypox virus. Swab lesions using needle, or scab or crust tissue using scalpel. Then you can do a skin lesion swabs. You can with sterile, put it in sterile container, and then you can do the IgM and IgG levels. The third step is important consideration: ensure the sample is closed and tightly. So this is important, although it looks simple, because it can people can get exposed to the fluid or the specimen that you have taken. Use double biohazard bag. Staff need to transport the specimen with frozen ice packs in upright disposition. Use category A triple packing. And then if the patient is confirmed positive monkeypox, then it needs to be transferred to Ain Hospital. So this is the Ain Region monkeypox pathway. Next question, before coming to the vaccination, monkeypox, Mr. Smile, can we have the question, please? Monkeypox vaccine should not be given to the following: patients with hypertension, elderly patients, immunocompromised patients, patients with pre-existing skin condition. We can start, can give you 30 seconds, and then everybody can answer. So monkeypox vaccine should not be given to patients with hypertension, elderly patients, immunocompromised patients, patients with pre-existing skin condition. Okay, we can show the answer, please. Okay, very good. So I think people are probably participating very well. So immunocompromised patients, we should not give the vaccine. We can close it now. So there are 2 types of vaccines available that can reduce the risk of developing monkeypox. The modified vaccinia Ankara, this MVA vaccine, which is also called Jenius in the USA, or Imirex, Imvanex in Europe, and other names like ACAM 2000 vaccine. So there are different names. Usually Jenius, we name it over here also in our part of the world. The MVA vaccine is made of highly attenuated, non-replicating vaccinia virus and has an excellent safety profile even in immunocompromised patients. Now, this vaccine can be given in immunocompromised patients, but the other patient we will discuss in a little bit, that cannot be given. and also with skin disorders. The MVA vaccine is administered as 2 doses, 4 weeks apart in US and approved for the prevention of smallpox and monkeypox. This vaccine, which is also called ACAM 2000, is a replicant complement smallpox vaccine that can only be used in select patients and associated with more adverse effect than the MVA vaccine. Now, the ACAM vaccine, let's go behind. So 2 vaccines, one is MVA vaccine, the second one is ACAM vaccine. So ACAM vaccine cannot be given in immunocompromised patients, but MVA vaccine can be given in patients with skin conditions and the patients who are immunocompromised. So now we are discussing ACAM vaccine. This is a replication and competent smallpox vaccine that can only be used in selected patients associated with more adverse effects. So remember, this is a component of a smallpox vaccine. ACAM vaccine is approved for prevention of smallpox, also can be used for monkeypox under expanded access investigational new drug application through CDC. So it can be used in a specific population. So which population is that? You know, the population who are not near to elderly or immunocompromised patients. Now here the important point is, until the site where you have given the vaccination is not healed, you're not supposed to be near the person who's immunocompromised, who's on chemotherapy, or the patients with multiple immunocompromised conditions, as we discussed earlier. So this is the vaccine that we shouldn't be giving to the people who are immunocompromised or pre-existing skin conditions, or mostly immunocompromised patients. So in summary, if people want to just listen to the summary, monkeypox is an orthopox virus, was first isolated in the late 1950s from a colony of monkeys. Distinct strains of monkeypox exists in different geographic regions in endemic countries. The strains isolated from West Africa appears to be less virulent than from Central Africa. Human-to-human transmission of monkeypox virus can occur through several routes. Close contact with infectious skin lesions. The current global outbreak is non-endemic. In non-endemic countries has been primarily associated with close intimate contact, such as during sexual activity. Transmission, large respiratory droplets as a close contact. Monkeypox virus can also be acquired through contact with an infected animal's bodily fluids or through a bite. Monkeys and humans are incidental hosts. The reservoir is likely to be certain rodents. Clinical feature, as we discussed, are fever, lymphadenopathy, flu-like symptoms, and usually the incubation period is 5 to 13 days. During the global monkeypox outbreak 2022, the incubation period has ranged from 7 to 10 days, and most patients with monkeypox have a self-limited illness. Clinical presentation is fever, chills, myalgias, and a rash. The rash typically begins as macules and evolves as papules, vesicles, then pseudopustules, and then later on it crusts, and crusts dry up and then falls off. Over here, the patient is non-infectious once the crust falls off. The patient also have also presented with proctitis, tonsillitis, and encephalomyelitis. These are rare complications of monkeypox. Treatment and vaccines, we discussed there are antivirals, Cidofovir, and vaccines, we discussed 2 types of vaccines. So with this, I will end my presentations and would be happy to take any questions.
Thank you very much, Dr. Aqeel, for this excellent and interesting presentation update on monkeypox. I want also to thank the team of the IBH led by Professor Grivna and the College of Medicine. They make it possible this webinar to happen tonight. I would like also a special thank Mr. Ismail and Dr. Azhar for this excellent coordination of this tonight webinar. I would like also to thank the participant of this webinar tonight. So our next webinar will be on October 25th, and the speaker will be Dr. Adil Mikhail.
Professor Mahmoud? Yes, we have some questions if you can read them and discuss them with Dr. Aqeel.
So, okay, now we will start with the questionnaire or the speaker's conclusion.
The question, please.
The
So
question.
let's take
okay.
the questions from that. Yes.
Yes, okay, so thank you,
Dr. Aqeel, if you can stop sharing your screen, please.
Oh, sure.
So, Dr. Prof. Mahmoud, we have a question from Suad. She's asking Dr. Aqeel, is there any incident of asymptomatic people spreading the disease?
Yeah, as I mentioned, patients who are asymptomatic that can also spread the disease. This is probably in incubation period. During incubation period, the person itself doesn't know that he or she has a disease, so they can still spread the disease. But I would say most likely the person would be having a little bit of flu symptoms, lymphadenopathy, and influenza-like symptoms, viral-like symptoms. They probably would know that they are having some kind of viral illness. But yes, they can spread the disease.
Okay, great. Another question from Mr. Khair saying, thank you so much, Dr. Aqeel, excellent and informative presentations. My question is, many cases in this outbreak are not presenting with the classical clinical picture for MBX. So any explanation for that?
Yeah, I think multiple people usually does not present with a rash. If we don't see a rash, we probably don't say that this is a monkeypox. So I think we have to be careful. There are certain population that probably might not present with a rash. So we need to be careful that maybe a few, like 10, 15, 20% of people would not present with a rash. If there is a viral illness, like influenza-like illness or lymphadenopathy, we need to think about monkeypox, and especially if the people are from high endemic countries or if the patients have a contact with any person who has monkeypox.
Another question from Suad. It seems she enjoyed the presentations, and she's asking, does the transmission stop after the scabbing is over, or does the person still transmit to others?
Very rarely. If there is a scabbing done and it falls off from the skin, very rarely the patient or the person is infectious. So after this, the scabs falls off, the person mostly is non-infectious.
Great, that's good to know. Please, Ismail, can you unmute Prof. Muhammad Abid? He wants to speak up. Prof. Abid, the mic is yours.
Okay, thank you very much, Dr. Aqeel. It's a very interesting talk. A couple of questions I have. I think the first question is monkeypox a sexually transmitted disease? I was in the UK in summer. I think that's how it started with. So I'm not sure what's the current view since we had many more cases, during summer, both in the Europe and also other side of the ocean as well. And the second question is from the public health perspective. So what we can do to do the early detection of these cases, and obviously then we can manage them at early stage and prevent them the serious complications. But the second question is how we manage the contact tracing, because initially the illness can be either asymptomatic or with the mild symptoms, and then it can infect other people, whether it's the household contacts or the sexual contacts. What's your advice would be on that? Thank you very much.
Thank you, Professor Muhammad Abid. very interesting questions. I actually went through it. There are cases of homosexual males, who can have this infection. That's why I wrote in one of my slides that proctitis is one of the complication of monkeypox. So initially it was detected. Still, there are many publications in which the homosexual males are more prone to get monkeypox. And it is correct. In USA, UK, Europe, the people are more, they are thinking more on the side of contact with homosexuality or heterosexuality. And it is more of a contact from the sexual transmission rather than the skin to skin contact. So yes, it is it can be transmitted sexually. The second part of your question is how can we do early tracing? So the person who is from high endemic area or visiting or coming from a high endemic area like Central Africa, West Africa, and then if they develop influenza-like symptoms, fever, lymphadenopathy, and a rash, then probably we are thinking about that. Now, if the person who is probable or possible case of monkeypox, then we start investigating him. And then if the PCR positive, then probably we will notify a Department of Health and they will start tracing like we did in COVID. If we remember that once the COVID is positive, they usually Department of Health start calling the person who has been positive with COVID, and then they do a contact tracing.
I mean, is there anything we can do to increase its awareness among populations so that people, when they suspect the symptoms, then they can contact the medical specialist at early stage?
Actually, not really. Recently, we don't have a lot of cases of monkeypox, and it is not to that stage of COVID that we are going to catch it as early as possible. It is, I think, it's less I think we have handful cases. We don't have a lot of cases, but still it is important to identify monkeypox early. As I said, maybe more than 90% of cases are mild. They would not go for moderate to severe cases. So I think still we have a window until we reach to that level that we are going to pick up the early cases.
Thank you very much. Thank you.
Thank you, Prof. Abed, for your questions. Prof. Mahmoud, do you want to say something?
Yes, can you unmute?
Yeah, you are on mute. Please go ahead.
Yes, Dr. Aqeel, thank you for presenting this Ain Region pathway of dealing on monkeypox. So could you give us how we are here, the cases here in UAE or in Ain, please?
Yeah, actually, the suspected or probable cases are a lot. People, anybody who gets a rash, they come and then we try to investigate them. And maybe 50% of them go back home, and then we don't do a PCR on them. The people, as I said, who are highly suspected or they are coming or they are in contact with monkeypox patients, we do a PCR on them. And if the index of suspicion is low, we send them home, and then we will trace their PCR and we'll call them if it's positive or negative, both ways. And if the index of suspicion is high, we tend to transfer them to Ain Hospital and isolate them until the PCR is back. I don't think PCR takes a long time. It usually takes 24, 48 hours, so that we would probably be knowing in a day or two that whether this person is monkeypox positive or negative. The PCR is very sensitive and specific. So I would say it would detect most of the infection, maybe more than 95% of the cases.
Thank you very much, Dr. Aqeel.
Thank you so much. Actually, we're receiving a very positive comments from the audience. So they are saying, thank you very much. It's clear and everything is hard. Thank you for the hard work and appreciate the presentations. It's great. We have a questions from our PhD, clever PhD student, Ruwaida, and she's asking if those who took varicella vaccine as part of their childhood immunization schedule, do you think that they are immune from the monkeypox?
Actually, no. Varicella and monkeypox are two different viruses, So varicella actually, even if you get varicella, you can get varicella again, which is a zoster infection. So even if cannot immunize you from the varicella, it cannot immunize you from monkeypox. So no, I would say no. The answer is no. So varicella vaccine is different virus than monkeypox virus. The answer is no. There is a vaccine for monkeypox, but people are still not recommending very hardly about that. Maybe some people who are healthcare professionals who are dealing very highly with monkeypox patients, they probably would be recommended to take it, but still we are in the process that probably will not recommend that.
Great, thank you so much. Another question from Lamise, and she's asking, at what stage we can administer the antiviral medications, and when do you think they are most effective? At the beginning of the incubation period, or during the symptoms is appearing, or at the end?
Sure. So I think in one slide, as I mentioned, the antiviral medications would be most effective in the patients who are immunocompromised, like solid organ transplants, HIV patients with the CD4 count of less than 200, the patients who have leukemia, lymphomas, solid organ transplant, and the patients who have graft versus host disease and stem cell transplant patients. Those are the patients in which antiviral medications are recommended. Remember, this cidofovir medication, antiviral medication, is potentially very nephrotoxic medication. So we don't want to use in the patients who have mild symptoms or moderate symptoms, even moderate symptoms, and those are immunocompetent patients. Immunocompromised, although I will give mild to moderate for those, but I have used in very rare occasions cidofovir. I would say I haven't used in many of the patients this antiviral medication.
And the durations of the antiviral treatment? There's another question from Saeed.
Yeah, we have now, as we did in COVID, we usually gave it for 5 days, and I would say 5 to 7 days, although we don't have much of a data that how many days we would give, but ideally we should give it for 5 to 7 days antibiotic.
Great, very informative presentations. Another experience and question from Leila or Leah. She's sharing the major challenges they are facing in their country about isolating the patients, because she's saying that, or he's saying that the crust need to fall all so the patients is not becoming infectious, but that will take a strain on the healthcare system. So what's your experience and advice in this domain?
Sorry, did not understand the question again.
She's saying that since we have to isolate the patient until all the skin crust is falling, this is a major challenge, how to isolate such number of patients with the current pandemic, COVID and other diseases. So can we send patients home, or he's still infectious? So what's your advice in this domain?
Yeah, this is a very good question, actually. If the patient is immunocompetent and if it's a mild disease, usually we tell them if they have a separate room and a bathroom, they can go home and isolate themselves. And if they are not in touch or contact with their household members, they can go home and isolate themselves. So we don't have a high burden of patients in the hospital. So I would say in mild disease, immunocompetent patients, they can go home and take rest. Currently, we are admitting them in the hospital because we don't have a high burden of monkeypox disease. But later on, maybe once we have a high burden, inshallah not, when we are going to have, then probably we can send them home and they can isolate themselves.
I hope that answers your questions. So we have a question here. I'm not sure if we can answer it. How many cases of monkeypox we have here in Emirates? So I think this is up to the authority to come up, and now they're not even going to post the COVID cases, so no need to worry about the numbers. It's only about the precautions, and that's what public health is all about, is prevention better than cure. So everybody is saying valuable information, best regards. So I think we answered most of the questions. I think all of the questions has been answered. So I will leave the mic for Prof. Mahmoud to conclude today's webinar. And thank you very much from myself, Dr. Aqeel, for being here with us today. It's a real honor. Thank you so much.
Thank you.
Thank you, Dr. Azhar. I already made the closing remark. So
So basically, if you are interested in getting a certificate for today's webinar, please fill in the link that has been shared in the chat, and you will be getting a CME certificate with 1 credit category A. If you have any other questions you have for Dr. Aqeel, you can share them and email them. He's kindly accepted to share his private email with you. So the email is, as you can see on the screen. And we are looking forward to welcome you again to our next webinar, which is going to be scheduled on the 25th of October. For more information, please follow our social media accounts posted on the screen. And this presentation is actually being recorded, and we are going to upload it on our YouTube channel, Institute of Public Health, CMHS. So until then, stay safe, and we wish you all the best, and looking forward to meet you again on the 25th of October.
I really think a special thank you to Dr. Ismail and Azhar, their hard work to make this happen. How many days we were here again to rehearse and make it. So this was very good. And I would like also to thank the participant for their active participation, and they were asking very important, relevant. And a special thank our dear colleague, Dr. Aqeel, for his busy time. Even now he is on leave. He made it possible that he will present this tonight, a very interesting topic. So again, thank you very much, and have a good evening. Thank you very much.
Thank you. And I would like to ask the audience if they have any questions, they can email me. And thank you, Azhar, Ismail, Professor Mahmood, for organizing this. And thank you, audience, for your very extensive and good questions. And if you have anything else to ask, please do not hesitate. You can copy my email, and I would be happy to answer you. Thank you very much.
Thank you very much.
So much. Thank you. It's a pleasure to have you. Thank you so much.
Bye-bye. Thank you very much. Bye.